Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today we'll be discussing enhanced barrier precautions. The discussion will be a rebroadcast of our April 19th presentation by Quality Insights Medical Director, Dr. JStorm. And following the presentation, we will have a live Q&A. Everyone has entered the meeting on mute, but if you have questions or comments for our discussion, please submit them using either the chat or the Q&A tool in your Zoom menu. We encourage you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we will be discussing the end of the public health emergency and how that will affect nursing homes. And we will also have a special webinar in 2 weeks that will be eligible for continuing education credits called Providing Evidence-Based Care to People Living with Opioid Use Disorder. That will be an hour-long webinar on Thursday, May 11th at 1 p.m. And if you're interested in registering for this webinar or learning more, I will drop a link in the chat shortly with further details. And now I'm going to share my screen and start playing the recording of our presentation. And when it's done, I'll stop the video and we will have our Q&A. It will begin with my introduction of Dr. Storm, and it will take just a moment to set up and get the audio synced. Stop my video. Oh, wait. Redo that. Okay. Can
Kathy, you were correct the first time. We now see your desktop.
Let me try that again. I wasn't correct because I had to get the audio synced and I forgot to check that box. So I'll try this one more time. Share screen, share sound. Here we go. Okay.
There you go.
Go to hear the audio from inside of my computer to get good sound quality. And I will hit play and let me know in the chat if you are able to hear okay after I hit play. And now I'd like to introduce our guest today, Dr. JStorm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. She most recently served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again.
Thanks so much, Kathy, and thanks everybody for joining us. Recently, we've gotten a lot of questions on enhanced barrier precautions. So we wanted to conduct a webinar today, and I'm going to talk about a case, but I would encourage you all, if you have a challenging case around enhanced barrier precautions, to go ahead and save it for the end and share it so everybody can learn. So the objectives for today, we're going to talk about a brief history of MDROs, multidrug-resistant organisms. I know we've heard a lot about these and we deal with them on a daily basis in long-term care. So we're going to do a brief overview because we really are focused on MDROs with enhanced barrier precautions. So we're going to talk about how they're spread. We're going to talk about colonization a little bit, infections, and who is at risk for MDROs. We're going to talk about the CDC's rationale in recommending enhanced barrier precautions. And then we're going to talk about the guidelines and implementation of enhanced barrier precautions in the nursing homes. And this has been the subject of a lot of questions lately. Anything that's new brings up a lot of questions, especially in long-term care, because we have so much going on. I mean, there's so much documentation and there's so many procedures to follow. So it's really natural to have a lot of questions about a new procedure. So we'll be going through that today. So patient case, this is a 64-year-old female. She's admitted to a skilled nursing facility from the hospital after a stay for sepsis and chronic kidney disease. Hemodialysis is initiated during the hospitalization. So she has a tunnel dialysis catheter that's placed. 26 days after her admission to the nursing home, she's found to have a temperature of 100.2 and a heart rate of 108. So we know with sepsis tools, the easiest one to remember is 100, 100, 100. And here we have a temperature greater than 100 and we have a heart rate greater than 100. So we know that she's looking like she's septic. So we try to keep the patient in the facility and initial labs are drawn, but she is unresponsive the following day. So this is common, right? This happens a lot, especially with our hemodialysis patients. They have a change in condition very rapidly. So she's sent to the hospital and diagnosed with MRSA bacteremia from a dialysis catheter associated infection. So is this preventable hospitalization? Perhaps if we would have used the right precautions like the CDC recommends. So just as a review, what is a multidrug-resistant organism? These are typically bacteria, though we've been seeing a lot about a Candida species that's been resistant recently. I'm sure you've seen it in the news. So these bacteria are typically bacteria that are resistant to one or more classes of antibiotics. These are the bacteria that when you see a urine culture and you see R, meaning it's resistant to most of them, that's when you know you have an MDRO. These organisms are frequently resistant to the most common antibiotics. They're associated with longer hospital stays, increased costs, higher mortality. These make people really, really sick, and they're hard to treat because, as I've said before, when we have individuals in the nursing home, sometimes they have allergies to medication, so it's very challenging to pick an antibiotic that is suitable for them. And if we have a resistant organism, that narrows the antibiotic down even further. And then if we have compromised renal function, then that will narrow the antibiotic down even further. So it really limits our choice. And the prevalence of MDROs have increased a lot over the last few decades, especially in nursing homes, and probably that is driven by the number of antibiotics that we prescribe in the nursing home. So antibiotics are causing resistance. So when we look at colonization versus infection, colonization means that we have a potential bacteria present on the individual's body, may not be causing an infection. It increases risk for infection. So like our patient with the tunnel dialysis catheter, she was in the hospital, so she might have been exposed to MRSA. Perhaps she had it on her body, she was colonized, and it put her at risk of developing infection, and that's what happened. So individuals who are chronically ill, like patients who are on hemodialysis, immunosuppressed, or they've been recently admitted to the ICU, they are at increased risk of developing infections from bacteria that are already on their body, that they're colonized with. So what is the rationale for using enhanced barrier precautions? Our residents are at increased risk of becoming colonized with MDROs and developing infections. So we want to prevent colonization if at all possible, because we know when they're colonized, they're at increased risk of developing infection. We do know that about 50% of our nursing home residents may be colonized with an MDRO. So if we only look at infection, at residents who have an active infection, then we're really not looking at prevention. And when we think about prevention, what we really want to think about is transmission. So we want to prevent MDROs from being transmitted from one resident to another. So there's growing evidence that traditional implementation of just our regular old contact precautions in nursing home is not going to prevent MDRO transmission. So enhanced barrier precautions refer to the use of gown and gloves during high contact care, resident contact care activities. And so what really is happening, you think about when you provide resident care, say if you are changing a resident, you know, when you kind of roll that resident over and perhaps they roll against you, you might get an MDRO on your scrubs and whatever you're wearing, and then you move on to the next resident and do the same thing, and then you transfer whatever is on your scrubs to the next resident. So that is the rationale behind enhanced barrier precautions. That's why we're using a gown and gloves, and then just for the resident care that we're doing, and then we're throwing it out and moving on. MDROs may be indirectly transferred from resident to resident during these high contact care activities. So who are we using enhanced barrier precaution? What residents? Is it all residents? So we're using enhanced barrier precautions in residents who have wounds and indwelling medical devices. So they are very high risk of acquisition and colonization with MDROs. So we're using gown and gloves for high contact resident care activities. So this is when contact precautions do not otherwise apply. This is for residents with wounds, indwelling medical devices, regardless of them. We don't care if they're colonized with MDRO. We are just going to utilize them if the resident has a wound or an indwelling device. And also we would be using these for residents if we know they have an MDRO infection and we know that they're colonized. So for an individual that has a wound and an indwelling medical device, irregardless of if we know if they're colonized or not, we're using the enhanced barrier precautions. And then for residents that we know have an MDRO infection or we know that they're colonized, we're also going to be using the enhanced barrier precautions. So what are our examples of high contact resident care activities? Getting a resident dressed, bathing and showering, transferring, providing hygiene, brushing teeth, combing hair, shaving, changing a brief or assisting with toileting, changing linens. Device care. So anytime we are changing a urinary catheter, we're changing a feeding tube, we're changing a trach, we're changing a central line, we should be using enhanced barrier precautions during this care. And then wound care. CDC has a really great informational site about which type of wound care we should be using enhanced barrier precautions for. And then physical and occupational therapy as well, because sometimes that is high contact. So chronic wounds. So the intent of enhanced barrier precautions are to focus on residents who are at high risk of acquiring an MDRO over a period of time. So this includes residents that have chronic wounds. So we're not talking about skin tears. We're not talking about skin breaks. If they're covered with a bandage, we're not, that's not what a chronic wound is. So pressure ulcer, diabetic foot ulcers, unhealed surgical wounds, chronic venous stasis ulcers. All of those would be included in an individual who would be getting enhanced barrier precautions with care. So our indwelling medical devices, central vascular lines, our hemodialysis catheters, or if the patient has a indwelling urinary catheter, if they have a feeding tube, if they have a tracheostomy tube. So things to consider about enhanced barrier precautions. So it's enhancing the current standard and transmission-based precautions. So we're just putting another level in place to prevent MDRO transmission between residents. So during care, we're going to use gown and gloves for each resident during high contact resident care activities that I talked about. And then when you are finished with the resident care activity, you're going to take off the gown and gloves and you're going to move on to the next resident. Obviously, we're going to perform hand hygiene in between removing the gown and gloves and then moving on to the next resident. So it's not recommended for residents with C. diff. These residents need to be on contact precautions and isolation as per your facility policy. Residents do not require a private room because this isn't something that's going to be limited. These patients are going to typically have enhanced barrier precautions for the amount of time that they are in the facility, and they're not restricted to their rooms. So this is not isolation. So a resident is colonized with a MDRO in their urine, they have ESBL in their urine, and they get treated, you're not going to isolate them to the room forever, but you are going to use enhanced barrier precautions just because they are colonized with an MDRO. So more things to consider. It's intended to be in place for the duration that the resident is in the facility until if the wound is resolved or they have the tunnel dialysis catheter is removed and they have fistula placed. So if that is resolved, then we would go ahead and get rid of the enhanced barrier precautions, though if they're colonized with an MDRO, we would not. So it does not replace existing guidance regarding use of contact precautions. So it's intended to provide care when a resident is in their room during high contact resident care activities, so including transfers. This does not mean that we're going to use enhanced barrier precautions when the resident is in the dining room. We are not going to use it when they're out in other areas, except physical therapy and occupational therapy. So does enhanced barrier precautions work? So if you're like me, sometimes things get put in place and you question. I'm a curious person, so I want to know, does it work? Like this sounds wonderful. It sounds like it's gonna it would work, but let's look at a study to see if it works. So they did a study, and this was published in JAMA Internal Medicine in 2015. So the study looked at enhanced barrier precautions utilized in over 200 residents that had indwelling devices in 6 different nursing homes. So it was a good study. It was a good amount of individuals, and they compared it to a control group of also a little over 200 residents. So barrier precaution signs were placed on the doors to their rooms, inside the closets, and at the nurse's station on their medical records. So everybody was aware that enhanced barrier precautions needed to be utilized during high contact care with these residents. It also included active surveillance for infections and MDROs. They also promoted hand hygiene and structured infection prevention education in the control group. And the infection preventionists and the intervention facilities were invited to a conference on surveillance methods for infection. So a really great study. So what happened? There was a 23% reduction in the prevalence of all MDROs in the intervention group. So it's pretty significant. This is compared to the control group that didn't see that reduction. So when enhanced barrier precautions were used in these patients, they had a 23% reduction in the prevalence of all MDROs. There was a reduced incident of new MRSA acquisition in the intervention group compared to the control group. So another great thing, MRSA is probably the most common MDRO that we see in our nursing homes. So this is huge. There was also a reduction in catheter-associated UTI in the intervention group compared to the control group. Another pretty significant finding. Okay, so we know it works. So does the patient require a private room? No. So single patient rooms, as we all know, should be prioritized for residents who have an acute infection with a communicable disease. So that's influenza, COVID, hepatitis A, or for residents, if we have a private room available, for residents placed on contact precautions with acute diarrhea, if they have a draining wound or other site secretions and are unable to be covered or contained, if we have a private room. So shared rooms. Residents who are on enhanced barrier precautions may share a room with other residents. So facilities with capacity to offer single patient rooms or create roommate pairs based on MDRO colonization may choose to do so. This is fantastic if we can do that. If we know that a resident is colonized with an MDRO, and we know that there's another resident who has the same MDRO colonization, and if we can have them be roommates, that's wonderful. If there are multiple residents with the same MDRO in the facility, consider cohorting them in one wing to decrease spread. Sometimes this is possible, sometimes it's not. I know it's very challenging and it makes for creative room moves. So if possible, that this would be wonderful. So when single rooms are not available, we want to cohort patients with the same MDR in the same room. Oh, I think this is this is a duplicate slide. So, when cohorting patients with the same MDRO is not possible, we want to place MDRO patients in a room with patients who are at low risk for acquisition of MDROs. So that means if we have a patient with an MDRO and there's we can't cohort that patient with the MDRO in with another patient with the same MDRO. We want to put them in a room where the other resident has a low risk for acquisition of an MDRO and associated adverse outcomes from infection. So these are people that are not immunocompromised, that are no open wounds. So we don't want to put a patient who has ESBL in their urine into a room with a patient who has no MDROs and has an open wound. So we want to kind of think about these things when we put patients together as roommates. So signs. These signs are available on the CDC website, and the link is there. I don't know if we're all wore out with signs, but this is really helpful so we understand why we're doing what we're doing. And if you can share with staff that study, it's really significant. It made a big difference in a lot of patients' lives. And if we can prevent patients from going out to the hospital, that's fantastic. You know, MDRO infections are significant, especially in patients who are immunocompromised, like our dialysis patients. So patients can die. So this can prevent a patient from dying. So it's significant. So, you know, we put these signs inside the patient's room, inside the bathroom, at the nurse's station, so everybody is aware of what we should be doing. So again, these are just to signal to individuals that specific actions should be taken. And this sign is really great because it shows you exactly what you should be doing, in what order, and what you should be putting on. I don't know about you, but at the beginning of the pandemic, I was really happy to have these signs because the donning and the doffing was challenging at first. Even though I had been tested on it at some point in my training, I had to get tested on it again in the nursing home. So putting up signs has really been shown, especially signs that list a checklist of the series of events that an individual, a staff member should go through for the PPE, have really been shown to work. So I would highly encourage you to use these signs in your facility for enhanced barrier precautions. So we want generic signs, generic signs that just instruct individuals to speak to the nurse are not adequate. And I don't know if anyone, I don't think those are effective. It just says, please, you know, talk to the nurse at the nurse's station. It's really important to make sure that what staff need to do is listed on the sign. And obviously we're not going to include any information about why the sign is there. We can't do that in the facility, obviously, due to privacy. And it's a HIPAA violation and a violation of resident dignity. So we always want to make sure we have our resources. Again, as I said, the CDC has a lot of resources. I would go directly to their website if you'd like to download any of that material. Or you can feel free to reach out to me. I'd be happy to help you navigate. A couple people have actually already reached out to me about navigating enhanced barrier precautions, and I'm happy to answer your questions. I always learn when somebody asks me a question, so I'm happy to answer them. So these will be available in the slides. And
Okay, let me get my video back up and we will get ready to begin the Q&A. Here we are. Let's see, Dr. Storm, it looks like you're still with us. And we've got Deborah Wright here too to answer any questions. Deborah Wright is a quality improvement specialist. Okay, so at this time, if anybody has any questions, please submit them in the chat or using the Q&A tool. I do not see any in there so far. So for the next minute, I'm going to go over a couple of closing items. Let's see. So anyway, for anyone wanting to download the presentation slides, I have dropped a link in the chat. And while we're waiting, I'd again like to invite everyone to next week's webinar, where we'll be discussing the expiration of the COVID-19 public health emergency. That webinar will be the same time next week, Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats, which are each Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find a link to join those live chats in our webinar email reminders, as well as our Friday newsletter, The Last Minute Lowdown. And if you're not on the mailing list for the Last Minute Lowdown, but would like to be, you can contact me at ccaudell@qualityinsights.org to be added to our mailing list. And I will drop my email in the chat shortly, along with Dr. Storms, in case you have any questions for her today that we don't get to in the conversation. And now I will look to see, it looks like we do have a question that is in the Q&A.
Yeah, I can take that one, Kathy. Okay. So Crystal, there is a way to add that in NHSN. Only the facility administrator can do that. So if you'd like to reach out to me directly, I'll be happy to walk you through that. I will also, I don't know how I can. I have directions on how to do that step by step. So again, if you reach out to me, I'll put my email in the chat, or Kathy can. I'll be happy to assist you with that.
All right, thanks, Deb. That was a question about flu NHSN data, so a little unrelated. But if anybody else has questions, yes, please feel free to get in touch afterwards. Looks like, okay, yes, Deborah put hers. Okay, so we have a question that says, what about MRSA cultured from exposed bone in a wound? Wound is not draining and is covered with a dressing. Okay to leave with a roommate?
So I guess it really depends on who the roommate is and what their medical conditions are. With that exposed bone, you are, that would be considered to be a wound. So you would have to use enhanced barrier precautions with that patient. But just as far as cohorting, it would really depend on what other medical conditions the other patient, the roommate had.
All right, thank you for that question. And that's all the questions so far. So if anybody else has, oh, looks like we got another thing in the.
So let me find, Kathy, I will try to find it real quick. And if a couple people want to stay on once this webinar is over, I can show you that step by step for those that want to stay on, if Kathy's able to stay on.
Can you explain what they'd be staying on for? I don't think we read the question before.
Oh, I'm sorry. They wanted step by step on the process to add the annual influenza into NHSN for the healthcare providers.
All right, thank you, Deb. And I meant to add earlier that if you would like to ask your question out loud, you can use the raise your hand function, and we will, when we see that, we will give you the ability to unmute yourself to ask your question. So if anyone doesn't feel like typing it out, that's another way to do it. We'll take another minute here. Dr. Storm, thank you for sticking out with us. I know you have to run here soon. Okay, let's see. I think that's probably all we're getting for today. So I will go ahead and wrap us up. Before we sign off, I'd like to ask everyone here to please answer a short evaluation of our webinar. The evaluation is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. I'd like to thank all of you for joining us today, and Deb and Dr. Storm, thank you for joining us to answer some of these questions. For those of you who want to stay around for talking about the NHSN flu, just stick around here. I will not hit end on this webinar just yet, but for everyone else who is ready to take off, thank you for joining us today, and we hope to see you next week. Deb, will you be wanting to share your screen?
I just did, okay. I think.
There you go. Yes, you did.
Okay. So when you are in NHSN, you have to enroll you have to enroll to have that component added. So like I said, when you log in, you're going to go to facility, edit a component, And then you'll add a user for that component. So we recommend that you add multiple users, but you do want to at least add whoever's going to be inputting that information. But this is how the facility add a component, and the person that can add a component is only the facility administrator. So let me see if there's a screen here that shows that. Sorry for the scrolling. So I don't know, Kathy, this was in one of the other webinars we did. I don't know if you have a link for it or not, but if you just, here is the name of it. So this is, you can get the slides there, or again, you can email me and I'll be happy to share these slides with you. But that is how you have to do it, is you go to that right-hand side there, right here where it's facility, add edit a component, and then that's the safety, the HPS component will come up. You'll click that checkbox. I wish they had a screenshot of that, but they don't on here. So, but then that's how you would do that. So this PowerPoint does take you step by step how to do that. If you have any more questions, you can feel free to reach out. And like I said, we'll be happy to get this PowerPoint out to those of you that need it.
Still on mute. Someone asked if we could please share the slides. Tiffany, can you specify, do you want the NHSN slides or the slides from the Enhanced Barrier Precautions presentation today? Because I think I can mail either. I just want to be sure.
And maybe that's what we could do, Kathy. Can we just email these slides when you email the? Yeah,
that's a good idea.
Okay.
Yeah, so, okay, she wants the NHSN. Okay, so that's what I do. I always email everybody after following the webinar with the recording and the presentation slides. So I will include that and you'll get that to the email that you use to register. And I usually send that out on Fridays in the morning.
And we have been able to help a couple of facilities with technical difficulties. So if you do that and you are struggling, or if the person that is listed as your nursing home administrator is no longer your nursing home administrator, that's a whole nother process. So we can help you again with that step-by-step to work on that, but that's much easier done one-on-one as opposed to this kind of a session. So like I said, just feel free to reach out and we will get you those slides.
All right, and I think that's it for questions, but yes, I'll include that information plus some contact information when I send out that email on Friday with all of these resources. And I think, yep, that's it for questions. I'd like to thank everybody for joining us today. Deb, thanks for sticking around and taking that question, taking us through that screen share. And I'm going to go ahead and push end on this. Thank you all for joining us today.